I want to spend some time talking about house staff issues, residency issues, manpower issues, and I had some trepidation about giving this talk here at UCSD because this institution has such a remarkable tradition of excellence in both burn care and trauma that I was concerned you wouldn't be facing the same sorts of problems that we are, but I was reassured in the conversations I had last night that many of the problems you face are indeed the same ones we face here at Utah and in fact all over the country. So I want to talk about some of these issues with the idea that I think burn care has kind of been the first specialty in surgery to face up to some of these problems. Trauma care is following behind, and now we're seeing emergency surgery taking the same path and seeing the same kind of problems. So in this sense, it represents a bit of a step in evolution. There's an old adage for visiting professors that if you don't have any data, you should always show a picture of your institution. So this is the University of Utah Medical Center with the mountains in the distance. Alta and Snowbird are just over those peaks at the top of the screen. Park City is off to the left, and most of the city is in fact out to the right. We have a very different kind of catchment area and a very different kind of referral network than you guys do. I did a little bit of work on the internet yesterday to find out a bit about the UCSD Burn Center and found out that you treat all of the burns in San Diego County and I believe Imperial County. Well, there are more people in San Diego County than there are in Utah and Wyoming put together. So while you spend all of your time taking care of about 4 million people in a relatively small geographical area, we spend our time taking care of about 4 million people in a very large geographical area. I heard last night that you only admit about 5% of your patients by air. More than 50% of my patients are transported to the University of Utah by air, and the mean distance that those people travel is about 245 air miles. So I very commonly get involved in the transport of people from northern Montana or the Grand Canyon or the Idaho Panhandle, and it can take 6 or 8 or 10 hours to get these people down to our institution. So those problems are very different than yours, but once people get to the burn center, I think they probably face the same sorts of issues that they do here. This is a photograph from the Coconut Grove Nightclub fire of 1942 in Boston. It's a very famous fire that really began the era of modern burn care. Fluid resuscitation was first developed there, and many other modern techniques that are still in use today. And this fellow has, you can see the black discoloration of his left hand. In those days, they commonly treated burn injuries with gentian violet and tannic acid in order to tan the surface of the burn wound and turn it into a hard crust, which would presumably be impermeable to bacteria. And that was the way that these burns were routinely treated. And then they would let the eschar separate, and if there was granulation tissue, they would attempt to skin graft the granulation tissue. And you can see a couple of hapless house officers here attending to this patient. And so that even at this period in time, more than 60 years ago, I think burn care got a reputation as work that was labor-intensive, that was hot, that was messy, that was not particularly intellectually stimulating. But the fact that the first burn center in the United States was actually organized clear back in the 1940s gives burn injuries, I think, a bit of a leg up over trauma and critical care, which really got organized as specialties a little bit later than that. Well, there were giants in the earth in those days, and there still are today. I often tell the residents at Utah that the one thing that got me into surgery and stimulated my interest in surgery, more than the physiology and more than the interesting surgical procedures, were the people that you met in general surgery. And that began very early on for me at the University of Chicago, where I was a medical student on Dr. Moose's service back in the late Cretaceous period, and my interest in surgery was stimulated there. I went on to Utah, where I again met a number of very remarkable people. And my personal sensei was Dr. Glenn Warden, who is a really remarkable person. I think he was the best general surgeon that I ever worked with in my life. He was a passionate advocate for both his patients and his colleagues. And more than that, I think he had more fun being a general surgeon than anybody I ever ran into. And Dr. Warden and Dr. Hansbrough, who were contemporaries, were the people at whose knee I sat and learned the science and art of burn care. And Glenn had this quotation that I often use today. to remind people that even though burn care looks like it's kind of grubby and kind of easy and not very intellectually stimulating, in fact, there are a lot of tricks to the trade that can take a long time to master. I certainly am still on the learning curve and trying to work on that other 10% of burn care. Well, one of the other famous surgical sayings I learned, I picked up in the early 1980s when I was a traveling fellow for the American Burn Association, and I visited a large East Coast burn center, and on rounds I heard one of the residents say with a great deal of wisdom, well, you know, Dr. Saffle, NPDGB, and I thought that was some sort of a physiologic acronym for something that went on in burn care, and I asked him what he meant, and he said, well, you know, everybody knows that, NPDGB, that stands for normal people don't get burned. And NPDGB has been a watchword in our unit for many years. It certainly characterizes the perception that exists in both the public imagination and in the imagination, I think, of the medical community about what burn care is about and what constitutes burn patients. And I think, again, burn patients were the first ones to be singled out by society and by the medical community as a group of patients that maybe are not quite so desirable. And I think much of the success of burn centers has stemmed from the fact that we take care of people that other people don't want. And I think we're seeing that, again, spreading into the trauma world and into the general surgery world. So what facts do we know about burn populations? Well, we know that their children and the elderly are disproportionately represented and they have a much higher likelihood of dying. We know that Native Americans are injured very commonly. We know that low-income families are very much more likely to get burned, and this data stems from the era before smoke detectors were widespread. But even with the advent of smoke detectors, I think that this remains true. Rural Americans are injured more commonly than urban Americans, and we get a lot of rural Americans from Idaho and Wyoming and Montana in our burn center. More than half the fatal house fires involve cigarette smoking. Alcohol and drug abuse is very common among burn victims. And all of this information together, I think, draws a picture of a population that is, that may or may not be normal. I'm not in a position to say that. But certainly they are underinsured and they are disenfranchised. And on the one hand, they certainly need advocates to speak for them. But on the other, it is very easy for many hospitals to regard them as less than completely desirable patients. And they present a lot of financial challenges to burn centers, which have led to many burn centers closing in the last couple of decades in the United States. So the attitude that people have about burn victims is that burns are unpreventable. They happen to people that aren't completely normal. Somebody has to take care of them, but I'm glad it isn't me. And I think that's the attitude that has led to the success of many burn centers, because we have natural monopolies in our catchment area for these patients. Well, as a consequence of that, over the last 25 years, burn centers have decreased in number significantly in the United States. Now, some of this is due to prevention efforts, which have been very effective, and I'm very glad to see that happen. But a lot of it has been financial. Some of it has been due to an inability to recruit personnel. And the few remaining burn centers that exist have become more centralized and larger. In addition, with this few number of burn centers, it's really impossible for us to provide good burn care education to the entire medical community in the United States. And as a result, not only do many physicians get through residency without ever having any formal instruction in burn care, it's even possible for general surgeons to get through their education without having any formal instruction in burn care. And a gap exists between burn centers and the rest of the medical community, which is getting wider and wider as burns injuries become less frequent. And there are many people out there who really don't know anything about burns and tend to refer everything to burn centers. I looked through one of my early textbooks for a pithy quotation about burn care, and I came up with this one, that there's no injury that is treated less expertly by the medical profession at large than a burn. And this was said in 1977. Now, 30 years later, I think that's even more true. And some of the mismanaged patients that are referred to me and some of the poorly evaluated patients that are referred to you, I think, are eloquent testimony to this. And when we get together at burn meetings, we all talk about the 50% second-degree burn that's referred to us. It turns out to be a 10% third-degree burn, and the over-resuscitated patients and the under-resuscitated patients, and the patients who get intubated and don't need it, and the patients who don't get intubated and do need it. And it's a real problem for us. And again, it has kept us busy because we get all of those patients referred to us, but it doesn't provide much educational overlap for the rest of the medical community. And I looked on the ACGME website to confirm what I already knew, which is that burn care experience is not a required component of general surgery training, and that burn experience can only be counted toward non-operative trauma. I think that's a shame. There was a time in the 1960s when burn care was the cornerstone of physiologic education for people in surgery programs, and that has obviously fallen by the wayside, and we've become a little bit more isolated, and we are regarded sometimes as not being really in the mainstream of surgical education. This is a review from the state of Washington of the payer characteristics of patients admitted to various hospitals in the state of Washington over about a 10-year period of time. There were 16,000 patients reviewed, and they looked at the patients, the 8,000 patients that were admitted to the Harborview Burn Center, which is the burn center for the state of Washington and for the University of Washington. And the point that I would make is that underinsured patients are more than represented among the patients admitted to the university system. Now, that might be selective referral based on financial status, and certainly that occurs in burn centers as well as trauma centers. This may partly be the nature of the beast. I've already showed you that underinsured and uninsured patients are disproportionately represented among burn victims. But for whatever reason, Harborview gets more than their share of people that can't pay their bills, and that is obviously a big financial stress for the burn center. And I think it helps you understand why maybe some of the other local hospitals aren't quite so interested in taking care of these patients. This has had a couple of other interesting consequences. One of them is that over the years, the burn size admitted to U.S. burn centers has gotten smaller and smaller. And in comparison to the 1960s, when only about 26% of patients admitted to U.S. burn centers had burns under 10% of the body surface area, and 11% of the patients had burns over 50% of the body surface area. Today, 62% of the patients we admit have small burns, and only 4% of the patients that we admit have truly very large injuries. Now, we like to take care of big burns, and I expect you do too. They're very challenging, they're very satisfying. The nurses and the residents get a lot of satisfaction and interest out of taking care of big burns. But I tell my nursing staff over and over again that we're really in the small burns business. That's what we do for a living. And we have to get those people treated in a timely manner. We have to treat them efficiently. We have to get them back to the workforce as quickly as we can. And I really think that's the benefit that burn centers provide to society. Everybody loves the 80%er. Everybody has a few trophy patients that they like to show off. But I think it's a steady stream of people with relatively small injuries, burned hands, burned feet, that we are able to get up and back to work and back to normal lives that really constitutes the benefit that we provide to the communities that we serve. The other thing that's been happening, at least in my center, and I've talked to several other centers that have seen the same thing, is that our numbers are going up. There are very few new burn centers. There have been, I know you had a talk here last year from Dr. Bill Chaffee at Providence, and Providence kind of created its own burn center when the Station Nightclub fire occurred. That's one of the very few new burn centers that's opened in the United States in the last couple of decades. So our numbers are very gradually going up, and what they are going up with primarily are non-burn admissions. We are seeing more and more people with necrotizing fasciitis, big soft tissue infections, open abdomens, skin disorders, and other things. And I think this represents an extension of this culture of convenience. Those patients are hard to take care of. The expertise to take care of them doesn't exist in the general community, and I think people simply find it easier to refer those people to the burn center. So as burns are decreasing in incidence, many burn centers are kind of becoming wound care centers and taking care of a hodgepodge of patients with difficult medical problems. Again, the kind of problems that I think other people don't want. Lee Fauché, who was a resident of mine, actually went on to become a burn surgeon and did a survey among U.S. burn centers looking at manpower issues, and he got responses from 247 burn surgeons, of which 28, I'm happy to say, are women. But of those 84 U.S. burn centers, 29% of them are currently trying to recruit a surgeon, and I can tell you it can take 4 or 5 or 6 years to find a good burn doctor to help you out. An additional 38% of centers anticipated a need within 5 years. 89% of those centers anticipate difficulty in recruiting, and I get emails regularly from other academic institutions wanting to know if I have any burn doctors that they could interview or hire, and I usually respond that if I could find anybody, I'd hire them myself. My recent junior partner that we hired 3 years ago took us 5 years to train and to bring on board, and I think that's a very typical history. And the biggest problem isn't even that we don't train burn doctors, but that we don't keep them in the workforce. So of 155 surgeons who completed fellowship training in the last 10 years, only 40% are still practicing as burn doctors. And we talked about this a little bit last night, that some people use a burn fellowship as a bridge to plastic surgery, or they do it to mark time while they're waiting for some other career move to occur. And they don't stay in the U.S. workforce. They don't gravitate to the burn centers who need them. And in that sense, the fellowships are not as effective in training our successors as they should be. And that's a big problem, and I'll come back to that in a minute or two. So if we put burn care in perspective, I think that burn care was the first of the surgical specialties which was perceived as hard work, and I think it is becoming increasingly removed from the mainstream, both of general surgery practice and general surgery education. The number of burn centers is declining. Jobs are hard to fill. Plenty of people have commented that burn care is not a lifestyle-friendly specialty. You have to work on weekends. You have to come in at night. You have to be available when your patients need you. And this lifestyle issue is competing with obviously lots more attractive issues for other kinds of surgical specialties. The general knowledge and interest in burn is declining. I read an article from North Carolina that reviewed their emergency room database and indicated that 97% of the burns treated in North Carolina hospitals are treated by emergency physicians, not treated by burn centers. And many emergency physicians receive no formal training in burn care. We have an emergency medicine residency at the University of Utah. Our residents get 1 month on the burn unit as interns. They never return to the burn unit again, and that's their burn training experience, and that's more training than a lot of people get. So it's a big problem that burns are simply not well known or well understood in the United States. The remaining burn centers are increasingly busy, but with smaller burns and with non-burns. The issue of selective referral is becoming to be related to inconvenience and inexperience, as well as the traditional indicator, which is financial. So these are the problems that burn centers are facing in this day and age, and I'm going to try to make the case that trauma centers and acute care surgery programs are in the same boat. Well, trauma centers also have a rich tradition, and San Diego has played a big role in that. Beginning in the mid-1980s, trauma systems and trauma centers became well organized. A number of papers, including papers from this institution, demonstrated that trauma systems reduced preventable deaths, decreased delays, and improved the quality of care almost everywhere they were applied. And there are lots of studies, including one from Salt Lake City. There's absolutely no question that trauma systems work. And trauma centers were one of the groups of hospitals initially cited on a growing body of evidence that relates outcomes to experience. And we now know that your survival from a pancreaticoduodenectomy or an aortic aneurysm or a carotid endarterectomy is directly related to the experience of the surgeon and the experience of the institution. And this was demonstrated with trauma care probably before it was demonstrated for any of those other types of surgical care. But that has led to problems for trauma centers that are not unlike the problems faced by many burn centers. Around the country, numbers are going up and acuity is going down. Trauma centers are being inundated with routine cases. As the case numbers go up, you get complacency, mistakes occur, and there is even data now suggesting that after trauma centers get to a certain size, mortality rates begin to go up. The system simply gets overloaded and it can't provide the individualized care that patients need. Within these institutions, trauma competes for resources, beds, nurses, and other facilities. In my hospital, I know the cardiovascular surgeons absolutely hate the trauma service because the trauma service is always filling up the ICU beds and putting us on divert, and then they can't do their elective cases. This is leading to what has been called de facto specialization. The trauma surgeons are so busy doing trauma, they don't have time to do anything else. And nobody else wants to be part of the trauma service because they perceive it as so consumptive of time and so demanding of their resources that they opt out of it as soon as they can. And as this gets busier and busier and trauma gets more and more demanding, it burns people out. And it's been said that it is simply not fun. Taking trauma call one night a month and getting an exciting patient or two in is very enjoyable. Taking trauma call 2 nights a week and staying up all night every night is not enjoyable, and it gets people out of the business, and that's one of the big problems that we face. But part of that is the trauma center's fault. Trauma centers have not been inclusive. I think San Diego County probably has a better organized trauma system than just about anywhere else in the country. But in many places, trauma care is a competitive business. It certainly is in Salt Lake City. We have 2 competing air medical transport systems, Life Flight and AirMed, and Life Flight and AirMed are always trying to beat each other to the scene of the accident so they can scoop up the patient and bring it to their respective hospitals. Cooperation is limited. Small centers are often denied a meaningful role, and when little hospitals call us with trauma, we tend to be rather short with them and just say, well, just send the patient to us and don't try to take care of it yourself because you don't really know what you're doing. We develop standards for trauma care at trauma centers, which really aren't very translatable to the surgeon in practice. So that encourages the surgeon in practice to not be involved in trauma care and to refer routine, relatively minor cases to the trauma center. The trauma specialist is sometimes perceived as elitist, as burn doctors sometimes are. Trauma systems don't work as well as trauma centers. Again, that may not be the rule here in San Diego County, but it's certainly true in Utah, where all sorts of political problems interfere with the development of effective trauma systems. And we have tended to have the attitude that one of my friends calls eating our young. And this was characterized for me when one of my very best chief residents, a very bright young woman who was very enthusiastic, who wanted to do a trauma fellowship, interviewed at a very well-known trauma program in the American Southwest. And when she came home, she said that they did everything they could to possibly discourage her and to scare her away from their program. And they told her, you were going to be up all night and we're going to make you cry and you're never going to see the inside of a call room and you're going to work so hard. That's an attitude which I think is still prevalent in trauma centers in the United States. Old guys like me have the opinion that, you know, I went through it and suffered, so I'm going to make you go through it and suffer. And it's not the sort of attitude, it's not the sort of concept that is going to lead to the maintenance of trauma systems in the United States. So this has got to change. And it's one of the big problems that I think we face today. And I think it's very well picked up by bright young medical students and residents who see trauma surgeons as having this attitude, and the last thing they want to do is become one of them. Will future surgeons be interested in trauma? This is a review from 2003. They took a survey among 82 teaching trauma centers representing over 247,000 admissions. These are big hospitals with a mean of 1,500 major admissions a year. That's less than you have. 543 CAT scans per year, but only 82 laparotomies. And they found that non-operative management was applied to 94% of splenic injuries, 95% of liver injuries, and 92% of pancreatic injuries. The authors estimated that the average resident will need to care for 500 blunt trauma patients in order to perform one splenectomy and one liver repair. I don't think the numbers are really that bad, at least they're not that bad at my institution, but it's certainly true that the vast majority of trauma care is non-operative. We turned over our residents on July 1st, as you did. One of my chief residents on the trauma service told me she's still waiting to do her first splenectomy. She's almost through the busiest month of the year in our service, and she hasn't seen a blunt splenic injury yet. So this is a big problem. It's certainly not lost upon smart residents and medical students that trauma is mostly non-operative and in that sense not very interesting. And that's going to get worse. This is data from the National Hospital Discharge Database looking at the demographics of patients admitted for trauma over a several-year period of time. And as you can see, the traditional trauma patient, which is the young man with a penetrating injury, is declining very dramatically in incidence and is being replaced by the older woman, probably with a blunt injury. So the trauma patient of the past was a 20-year-old guy with a gunshot wound. The trauma patient of the future is an old lady with a ground-level fall and a fractured hip. And those people will require a lot of additional care. They certainly are more consumptive of resources than young people. They'll spend a lot of time in the hospital. You're not going to get to operate on very many of them, and you are going to spend a lot of time managing their medical problems. And as people like me, the baby boomers, reach retirement age, that problem is going to magnify very substantially, and there may not be trauma people around to care for us when we fracture our hips. Are trauma surgeons viable financially? Do trauma surgeons make money? This is a review from Vermont that looked at a year's worth of trauma patients in this relatively small hospital, 344 patients. They found out that the hospital made lots of money. They made about $6 million taking care of these patients, and $3.5 million of that was profit. But the surgeons made relatively little money. The radiologists billed more than the surgeons did. And I think all small hospitals realize that what you really want to have in your trauma program is a CAT scanner. You get the patient in, you do a bunch of expensive CAT scans. If you find anything, you ship the patient to the trauma service. Your bill will get there before the trauma service's bill and get paid, and you don't have any liability issues because you're not providing any of the care. And that's what we see happening more and more in our trauma system. The surgeons involved spent 52% of their time in trauma care, but it accounted for only 16% of their billing. For these 344 patients, they did 19 laparotomies, whereas there were 211 operations performed by orthopedic surgery. So we are the interns of the orthopedic service much of the time, and that's how we often find ourselves being characterized. So there are transfer criteria which everybody knows are selective and are sometimes unspoken, but nonetheless well recognized. And the traditional one has been financial, and there is substantial information to document that. At the University of Washington, they found out that uninsured patients were almost 2.5 times more likely to be transferred to the trauma center than from rural hospitals than patients that were well insured. This was found to be true in the University of California review as well. I don't know if UCSD was part of that review. And lack of insurance in the Journal of Orthopedic Trauma is also an indication for referral to the trauma center. What's interesting to me is not that this traditional wallet biopsy issue exists, but that there are now other additional transfer criteria, selective referral criteria, which are not financially related, but rather convenience related. Obstetric patients who haven't received prenatal care are very likely to be referred to a university center for their deliveries. That happens to us at the University of Utah all the time. Patients with unsurvivable injuries are often shipped to trauma centers. They're shipped to trauma centers because a local hospital doesn't want to have a death on their books. They know the patient isn't going to survive, but they don't want to be responsible for that mortality, which makes them look bad. And interestingly, patients who weighed more than 300 pounds are more than likely to be shipped to a university center. And when I read this article, I said, I knew it. I knew they were doing that. And it's been happening to us. It's been happening to us for years, and I expect it's been happening to you as well. Here's a very interesting paper from the University of Illinois. They looked at all of their state registry, trauma registry data over a 4-year period of time. And during that period of time, in Illinois, as in California, they have level 1 centers and they have level 2 centers. And the only difference between level 1 centers and level 2 centers is supposed to be teaching and research. They have the same staff, they have the same OR capabilities, they have neurosurgeons, they have orthopedic surgeons, they have all of the same clinical resources at both types of facilities. The only difference is supposed to be research. And during the period of time of this review, trauma patients in this state of Illinois registry increased by 6%. But trauma transfers to the level 1 facility increased by 34%. Most transfers were from level 2 to level 1. No real reason for that to occur. Head injuries increased by 14%, but transfers increased by 44%. Orthopedic injuries increased by 25%, but transfers increased by 48%. And the 3 variables most predictive of transfer were orthopedic injury, head injury, and number 1, arrival at the original ER between 3 o'clock in the afternoon and 7 o'clock in the morning. So these are convenience-related issues. And we see this happen to us all the time, and I expect that you see it happen as well. Trauma centers are being inundated with low-complexity patients. We get seduced into a sense of complacency because we see patient after patient who isn't very sick, and then when we occasionally get the very sick one, we may not be as well prepared to treat that and to respond to that issue as we would be if we kept our guard up a little bit more. And of course, these large numbers of trauma patients stress us financially. They stress the other resources of the hospital. They make the hospital maybe a little bit less inclined to support trauma to a tremendous extent. So the 2 modern famous surgical sayings that I encounter all the time are, our surgeons don't take call. I hear that from small hospitals around the Intermountain West all the time, and I'm not comfortable with that. This is usually said by a general surgeon at about 10 o'clock on Friday night when he's looking at somebody with necrotizing fasciitis that he wants to transfer 400 miles to my hospital to get operated on. Well, I'm not very comfortable with it either, to tell you the truth, but I have to operate on those people and I get stuck with them, and that's the way the referral system works. How has this information impacted residency training, and how have smart young residents reacted to this information? This is an older paper from 1992, but is still very relevant today. I think he surveyed almost 1,800 senior trainees at 292 programs and asked them some questions about trauma care. Do you believe trauma is an attractive career? 63% yes. Would you characterize yourself as interested in trauma? 81% yes. Are you interested in a career in trauma? Only 18% yes. In other words, trauma is a lot of fun, but not for me. I'd rather have somebody else do it. Would you be willing to take in-house call? Only 22% of residents who were currently taking in-house call would be willing to do that as attendings. And are you interested in a trauma fellowship? Only 8% of residents said yes. There were positive write-in comments. There were 6 positive write-in comments. Trauma was exciting and challenging. It's enjoyable. We have a duty to care for the injured. There's a strong emphasis in our training, and I have an academic interest. So that looks pretty good. There were 430 negative write-in comments. Lots of work, too much night work, negative patient factors, too much work, detracts from our elective schedule, and fear of litigation. In fact, the fear of litigation argument, which is put forward all the time, is probably not true. There is no conclusive data that trauma is any more likely to get you sued than any other type of surgical practice, but it's very often used as an excuse by people that don't want to be involved in trauma care. Here's a national survey of trauma surgeons conducted in 2006, sent to members of all of the 3 big trauma organizations in the United States, 379 responses. Half of these people take in-house call. A third of people receive a stipend for doing so. I take in-house call. I get paid for doing so. 90% felt undervalued by society. Well, I'm not sure any of us care about that. But 83% favored including more broad-based general surgery. And when they were asked to list their most important disincentives, poor reimbursement and hours were the 2 leading ones. Inadequate operating was also very common. In-house call was an issue, malpractice less of an issue, and very few people felt it was uninteresting. They thought it was interesting enough, just too much work, too inconvenient. When they were asked to list impediments to trauma surgery as a career, number 1 by far was lifestyle. Lifestyle issues are interfering with people going into trauma. And again, medical legal risk is kind of far down the list. And if they were asked to list their ideal practice characteristics, the 2 important characteristics were money and lifestyle, which is not very surprising. More general surgery also shows up on that list. Less night call also shows up on this list. Remember, these are the people that are doing it. If you gave the same survey to 400 general surgeons that didn't take trauma, you'd probably get exactly the same answers, except that they would be stated more emphatically. So these are problems that plague practicing trauma surgeons as well as people looking at trauma from the outside. So I'm going to switch off of trauma for a second, but I want you to remember what I've said, and we're going to talk about emergency care for a few minutes and how emergency surgery is being developed as a specialty in this country. Here's some interesting facts about the emergency room. 1/3 of U.S. citizens use the ER as their family doctor every year. In other words, they don't have any pretense of going anywhere else. If they have a cold, if they've got a sore knee, if they've got the flu, they simply come to the emergency room. That's 114 million visits to the emergency room in 2004. 35% of those are after injury. Injury is the commonest cause of people presenting to an emergency room for care. Now, not all these people have major trauma, but they all have something of a traumatic nature wrong with them. The 3rd most common complaint in the emergency room is abdominal pain, and we certainly have more than our share of those. 16 million of those people came by ambulance to the emergency room. 500,000 ambulances were diverted. That's 1 ambulance diversion per minute, and in many urban centers, emergency rooms are routinely filled to overflowing. I went to the Southwestern Surgical Congress meeting in San Antonio, Texas, about 4 years ago, and when I was there, one of my chief residents who was there with me got appendicitis, and we took her to a local emergency room in San Antonio, Texas, and it was a scene out of a television show. A huge waiting room, jam-packed with people, patients throwing up into garbage cans, waiting 10 and 12 and 14 hours to be seen, people bleeding onto the floor. It's not quite that bad at the University of Utah, and I expect it's not that bad at San Diego. But there are many places where you don't go to the emergency room unless you absolutely have to, and you pack a lunch because you know you're going to be there for many hours before you ever get seen. 3/4 of all academic medical centers report overcrowding or divert in their emergency room, and we certainly go on trauma divert periodically because we run out of beds in the hospital. Over the last couple of decades, the number of hospitals in the United States has gone down. The number of emergency rooms in the United States has gone down in a commensurate way, but the number of visits to emergency departments has gone up. So like burn centers, like trauma centers, emergency rooms are being inundated with low complexity cases. And whereas emergency rooms were designed for emergencies, many of the patients I see nowadays don't really have much wrong with them, but they nonetheless need to be screened and treated. And this has led to a recognition of the crisis of emergency care, which really is our safety net for health care in the United States. And this copy of U.S. News and World Report was devoted to the crisis in the emergency room. And as you can see, the subheading is turnaways and huge delays are a surefire recipe for disaster, what you can do. And this was an absolutely fascinating article, and it was written in great depth, and it was never read. And the reason that it was never read is because it was published on September 10th, 2001. The next day, all of our conceptions about emergency care and trauma care and disasters changed very dramatically. And our focus was turned away from routine emergency care to the care of the victims of the 9/11 disaster. And I can't resist the opportunity to make a couple of asides here. Certainly, far and away, the most famous surviving patients from the 9/11 disasters were burn patients. There were 19 people treated at the New York Hospital Burn Center, and there were 9 people treated at the Washington Hospital Center, and those 28 patients probably got more press coverage than any other burn victims in the history of the world. The New York Hospital Burn Center, which at the time was the busiest burn center in the United States, was brought to its knees by this patient flow. They imported nurses from all over the country. The University of Utah sent a team of 3 nurses to New York who worked for 6 weeks in the burn center there. Many of us afterwards agreed that that was probably not the way that disaster should have been handled. Instead of moving the nurses, they should have moved the patients and farmed them out to burn centers which were already existing and prepared to take care of patients. But one of the most interesting asides that came out of this was a story in the Wall Street Journal in October of 2001, which contained the amazing statement, "There are no mirrors in burn units." And I guess the implication is supposed to be that burn victims are so hideously disfigured that they would never want to look at themselves. I can't imagine a statement which is less accurate or one which would be better designed to denigrate the image of burn victims in the popular imagination and the image of burn centers within the medical community. But even in this enlightened era, even with all of the positive publicity that the 9/11 victims received, the Wall Street Journal still thinks burn centers are places where people don't want to go. That was very upsetting to us. There is now an accumulating body of knowledge that I refer to as "don't get sick on weekends" that shows you that emergency systems are not really very well prepared to deal with emergencies. And all the residents probably know who Libby Zion was. She was the young lady who died in a New York hospital and started the move that resulted in the 80-hour work week because she was ostensibly cared for by an overworked resident who hadn't had any sleep and had been on all weekend. So she died on a Sunday night, and that's characteristic of what has been called the weekend effect. Here's a review of admissions from Ontario in the late night over a 10-year period of time. And what it demonstrates here is that if you have a ruptured AAA on a weekend, your odds of dying are about 32% greater than they are if you rupture your AAA during the week. If you have epiglottitis, you're 5 times more likely to die. If you have a pulmonary embolus, you're about 19% more likely to die. Now, these are real emergencies. There's no such thing as an elective ruptured abdominal aortic aneurysm, but if you present to the emergency room on a Saturday morning with a ruptured AAA, you're more likely to die than if you present on a Friday morning. Mortality was higher for 28 of the top 100 ER diagnoses, including a number of cancers, which probably makes sense because cancer of the breast really isn't a surgical emergency, and if you present to the ER with a cancer of the breast-related problem on the weekend, there's probably something else wrong with you, like a bone met or a liver met or a brain met or something else that is a complicating factor to your cancer. But the diagnoses listed here are true emergencies whenever they occur, and they're exactly the sort of thing which hospitals are supposed to be prepared to manage at all hours of the day and night, but they aren't. Here's a review from hospitals in California. 641,000 patients. I expect some of your patients are in this list. The odds ratio for death on the weekend was 1.03, not very great, but it was statistically significant. The highest statistical effects were seen with various kinds of cancers, duodenal ulcer, and cardiovascular symptoms. Unless we congratulate ourselves that as a major teaching hospital, of course, we would never be guilty of such occurrences, the weekend effect was substantially higher for major teaching hospitals, presumably because the professors are home sleeping and the junior guys are manning the trenches or for whatever reason. It also may be that major teaching hospitals get dumped on more on weekends than they do during the rest of the week, and they get more high acuity patients. But there is a substantial difference, a substantial weekend effect for many of the problems that present to emergency rooms. Here's a review from New Jersey, published in the New England Journal of Medicine last year, of patients admitted with a myocardial infarction over a 15-year period of time. 231,000 patients. Patients admitted on weekends were less likely to undergo an invasive procedure like a catheterization or a coronary artery bypass by day 2, and the odds ratio was 0.5. You are half as likely to get interventional therapy if you show up with an MI on a Saturday night than if you show up during the week. The cardiologists aren't there. The cath lab technicians don't want to come in from home. The system doesn't exist for these patients to be managed. It's not very heartening to know that the sorts of injuries for which emergency rooms were created are not being managed very well by emergency systems when they occur. And this is a mortality curve from the same slide. You can see that the mortality difference persists no matter how long you're in the hospital because you didn't get this emergency intervention in a timely manner. Well, this has been addressed in a lot of places, and it may have been addressed in Southern California. We're trying to work on this in Utah. In North Carolina, they formed a statewide regional network of what they call percutaneous coronary intervention hospitals. These are hospitals that are specially staffed and equipped to perform cardiac catheterizations at any hour of the day and night, put stents in people, get them operated on, whatever's necessary. And they compared patient care before and after the institution of this system. An important component of the system is that the emergency room physician can activate the cath lab team with a single phone call at any hour of the day and night. They have 10 of these so-called PCI hospitals and 55 non-PCI hospitals. Well, overall, the number of patients that were not reperfused went down very substantially. Primary percutaneous coronary interventions went up substantially. At the PCI hospitals, times improved, mortality declined, and at the non-PCI hospitals, referral times declined substantially. So this is a real success. And this tells you that with appropriate devotion of manpower and resources, these weekend effects can be resolved. Happily, there is no weekend effect at level 1 trauma centers, and I think we can all determine why. Trauma centers gear up for the weekend. Trauma centers know they're going to be busy on the weekend. When I take a trauma call on a Saturday or Sunday, I try to get a good night's sleep the night before. I pack a lunch. I tell my wife I won't be home for days, and we batten down the hatches and get ready to be busy. There is no clear weekend effect in critical care units if there is an in-house intensivist coverage. And it doesn't seem to matter what time of the year applies either. So people aren't more likely to die in July when there are new house officers. But on weekends, SICUs may have a higher weekend effect if there is no in-house intensivist. And of course, the intensivist who is in-house during the week tends to not be in-house over the weekend, which may account for some of these differences. The traditional surgeon that I trained with, that Dr. Musa taught me how to be, had a broad general practice. He was committed to the community and his colleagues. He took trauma and general surgery call as part of his practice and responsibilities. It wasn't regarded as a big problem. Everybody did it. You take a couple of nights a month. What's the big deal? Trauma and surgery call is service. We didn't do it for the money. We did it because, that's what you were supposed to do. You were supposed to help people. It's part of the community responsibility. The hospital expects it of you. So, of course, you do it. It worked because everybody did it, and everybody was on general surgery call and trauma call at one time or another. And trauma was considered a cornerstone of general surgical education and practice, very much the way burns were 20 years earlier. Well, how has that changed? Instead of a broad general practice, most general surgeons now have specialty practices in either boutique hospitals and clinics, or they do nothing but trauma. Driving over here today, I saw your beautiful new cancer hospital. We have a beautiful new cancer hospital, too. And it has parquet floors and room service and muted indirect lighting and piped-in music, and it's an absolutely wonderful place to be. But it doesn't have an emergency room. If you get your Whipple and go home and your Whipple leaks on a Saturday night, you're going to go to the old-fashioned university hospital to get your care. The people who practice in these boutique specialty clinics do a very good job, but because of their focus away from a general hospital, they lose their interest and skills in general care. They lose their commitment to general surgery call, and they're simply removed from the pool of available physicians who could help out with these sorts of things. A community commitment, which once was very common, has been replaced by very negotiated, restricted involvement. I interviewed a couple of people for critical care fellowships this year. The first question out of their mouth was, how much call do I have to take? When do I have to be in the hospital? How much time off am I going to have? Very, very protective of lifestyle-related issues. Call is supposed to be part of practice. Now, more than 90% of people who finish in general surgery in the United States go to places where they take no general surgery call. Now, some of them may be vascular fellows or endocrine fellows or surgical oncology fellows, and they may take some call as part of that, but they're not available for the pool of general surgeons who handle emergencies in the United States. Trauma call is service. I am very supportive of the 80-hour work week. The residents in the audience are going to have a lifestyle that's much more healthy than the one I had. It's more livable, it's more survivable, it's going to make you a better person and hopefully a better doctor. But the worst thing about the 80-hour work week and the emphasis placed on it by the ACGME is that we are teaching a generation of physicians that the word service is an officially dirty word. We tell our residents, you're not here to perform service, you're here to get an education. And if you're here afternoon on the day after your call, it's because you're performing service, and we don't want you doing that, we want you going home. Well, the take-home message to the residents is, I'm not here to serve people, I'm here to take care of my own interests and responsibilities, not perform service for the community. The idea that everybody does it has been replaced by, he doesn't do it, so why should I? And our call schedules at the University of Utah are very carefully scrutinized, and people count out how many nights the other guy has, and they go to my partner who does the call schedule and says, well, wait a minute, he's got 3 nights and I've got 4. How come that's true? And that seems to be true even among the people who take call, much less the people who don't. Trauma as a cornerstone of training. Trauma is now being proposed as an optional module in training. And trauma is going to be mostly non-operative no matter where you do your training. Even if you train in a high-intensity area like San Diego, you're likely to end up in a place where most of your traumas are blunt, most of your patients are elderly, most of the operations are done by orthopedic surgeons. So these issues have led to the proposal that we develop acute care surgery, a specialized team to perform all of the emergency procedures from the ER and consults. They do trauma, they do appendectomies, they do gallbladders, they do necrotizing fasciitis, and they concentrate these issues among a dedicated team of surgeons who are responsible for them. That's the trauma service in many places, and some people are talking about this as being a surgical hospitalist, much like the medical hospitalists which exist now. Here's some data. Here's an article on acute appendicitis managed by an emergency surgery service, an in-house acute care surgeon, or an on-call surgeon. And as you can see, the institution of the acute care surgeon didn't make the ER call people any faster, but once they were called, they got them to the operating room in about half the time. A substantial reduction in the time from presentation to the emergency room to the time they were in the operating room, a decreased incidence of ruptures, a decreased incidence of complications, and a decrease in hospital stay. So there's no question that when appropriately applied, the acute care surgery concept can improve patient care. Here's a review from Sacramento, your sister institution just up the road. They looked at 6 acute care surgeons and compared them with 8 so-called elective general surgeons. The acute care surgeons admitted about twice as many patients, but did slightly fewer operations. They did about the same number of operations per year as their elective counterparts. They admitted more people to the ICU. They did almost 20% of their cases between 10 o'clock at night and 6:30 in the morning, and 31% of their patients didn't have any money. So this may be a set of data which demonstrates the effectiveness of an acute care surgery model, but it is not data which is going to persuade young residents to go into acute care surgery. I don't think anybody is sitting in this audience saying, boy, that's for me. I want to stay up at night and take care of people that don't pay me. That's what I'm looking to do. So clearly, if we're going to make a system like this work, we have to provide other incentives and other support for the surgeons that are willing to do it. Here's a review from Denver General, 6 surgeons who do all of their on-call general surgery. They also do vascular and thoracic cases. How much worse can it get? They did 340 cases per surgeon per year, and as you can see, they did the majority of their trauma care on weekends, and they did emergent care really throughout the week. So again, they're busy. This is an effective system. I have absolutely no doubt that it's good for the hospital, but I can't look at this data and think that anybody will be attracted to this career as a consequence of that. These guys are very, very busy. They're doing a lot of operations. They're doing a lot of stuff on weekends. And unless some other concessions are granted to these people, this is not going to be a system that's going to sustain itself because nobody's going to want to do it. There is talk about the acute care fellowship and what the acute care fellowship will look like and what it will consist of. And this is a proposal that came from a consensus group in the American Association for the Surgical Association for Trauma, and it's a 24-month, it's a 2-year program that includes a substantial amount of critical care, because critical care boards, I think, are an important component of this system. But it also includes thoracic surgery, transplant surgery. You have to take transplant surgery so you can learn how to manage liver injuries, because we don't take care of liver injuries on the trauma service anymore. Only the transplant surgeons know how to do it. 2 months of neurosurgery, I'm not sure how much good that's going to do you. 2 months of head and neck surgery, 6 months of electives. Please notice burns are not listed on this sheet anywhere, which is kind of a pet peeve of mine. So 24 months of acute care surgery, 12 months during trauma call during this system. Now, these fellowships are out there, and I have had residents of mine go to them. And when you look at the data from these fellowships, it becomes very clear that the fellowships are tremendously popular in the hospital, and the reason they're popular is because the fellows are doing all of the work. They're staying up at night, they're doing the elective cases. This system is very, very heavily supported by the people that don't have to do it. And all of the elective general surgeons are very much in favor of an acute care system, because as soon as it gets instituted, they're off the hook and they don't have to take call anymore. That's a good argument for the system, but it's not going to keep the system running, and that's what I'm mostly concerned about. There is now an increasing recognition that the number of surgeons in the United States is going down. We don't have enough general surgeons to fulfill all of the needs that we have, even without acute care surgery as a specialty. This is much worse in rural areas, and this is a picture of a guy in some place called Massachusetts, Virginia, which I've never heard of. And he's the only surgeon in the place, and of course he's up all night, every night, taking out appendixes, and he's going to burn out. He's going to burn out, and he's going to start referring simple cases to the nearby university system, because it's going to be a convenience-related issue for him. And when he comes home, rarely, his wife is going to get on him about lifestyle issues, and sooner or later he's going to end up moving or retiring or going into fellowship practice or something else. Here's a very recent article from the Archives of Surgery looking at general surgery numbers in the United States. In 1981, there were 17,394 general surgeons in the United States. Now it's down to about 16,000. Surgeons per 100,000 has decreased by 28% in the United States during this period of time. There are obviously more women in surgery, which is a good thing because it gives us a much expanded workforce, and it speaks to the fact that the 80-hour work week is potentially making surgery more attractive to women, which is also a good thing. But there are fewer younger surgeons and more older surgeons now than there were in 2005, because it's guys like me that are coming to the end of their careers, and we are not being replaced by young surgeons joining up with the same frequency. This is an article from the Journal of Trauma looking at membership in the American College of Surgeons. Now, some young surgeons probably don't join the college because they don't think it's very relevant, but even given that, the numbers began to decline in about, people born in about 1960. Before that, the numbers were relatively stable and if anything, maybe increasing a little bit. Now they've declined by almost half. And that's not only because some people don't join the college, but much more than that is the fact that 70% of graduating chief residents now pursue other careers. They become plastic surgeons or cardiovascular surgeons or vascular surgeons or endocrine surgeons. And many of them don't end up joining the American College of Surgeons because they join their own subspecialty societies, which I think is a big issue. It would be easy for an old guy like me to complain about how soft surgeons are today, and young people don't have it like we did. And I walked 20 miles to school uphill when I was a boy, and to bemoan the status of surgical education. But I don't want to do that. I think a much more positive way for us to look at this is to adopt an environmentalist standpoint and try to see how we can make surgical manpower a green resource, a renewable resource. We want to keep surgeons around for longer. We don't want to burn them up and spit them out the way has been done in the past. What will do this? Well, I think the biggest single issue is not that trauma is unattractive, but simply that there are so few people doing it that the job is made unattractive. If you're on call every fourth night for trauma and you don't have any other responsibilities, it's not only a reasonable a job, it's also a job that can have a lot of lifestyle issues, because if you're a young mother with family, well, you have your 1 night in 4 where you're off at work and your husband has to take care of the kids, but the other 3 nights you're home without any call responsibility. You can spend all of your time with your family, and that may be a little bit less demanding than an elective practice where you may get called up at any hour of the day and night to go see people. The ACGME has been a major obstacle to this, in my opinion. At the University of Utah, we've been trying for 6 years to get an extra chief resident added to our residency requirement. We currently finish 5 chiefs a year. We'd like to finish 6. Every year we petition the ACGME. Every year they say that it's really not quite ready for that yet. During that same period of time, the population of Utah has increased by 10%, but we're not producing any more additional surgeons for the state of Utah during that period of time. We ought to be finishing 12 or 15 chiefs a year. So should you. That's the only way we will be able to make up for the manpower shortage which is looming for the future. The training has got to be incorporated, I think, into general surgery training. I continue to think that trauma is an essential component of general surgery. I think burns are too, but nobody will listen to me. We've got to try to do everything we can to make it attractive. The training can't be too long. Nobody wants to do 5 years of general surgery and then a 2-year trauma critical care fellowship. We've got to make it a little bit more reasonable than that. I think the concept of regionalization is here to stay. Again, instead of fighting it or complaining about it, we've got to embrace it. We've got to create regional acute care surgery programs which it is understood will take care of the appendectomies at night and the acute gallbladders at night and the necrotizing fasciitis at night. The hospital has to support this, and the system has to support this. So in a system like yours, which is heavily supported by the county, it wouldn't be unreasonable to ask the county to give UCSD a little bit more money so that it can take out all the appendectomies in the county at night. It's got to include relevant specialists. The disincentives that apply to general surgeons to take trauma call are much more significant for neurosurgeons and orthopedic surgeons who can make all the money they want in specialty clinics. Many of them are no longer involved in trauma at all, even though they may be more likely to operate on people than the general surgeons are. In my area, telemedicine is a big issue. When patients are 600 miles away, it makes a lot of sense to look at them on TV before you commit them to a $15,000 air transport. And we're having a hard time getting that to catch on, but I think it is getting to be a little bit better. The details must include salary. They've got to include time off, and I think that lifestyle is the driving issue for medical students and residents today. It isn't even so much money. You can't buy people at any price to take call for some of these systems. What you have to offer them is a reasonable lifestyle. And I have underlined sufficient staffing because it is very clear to me from having done burns for over 25 years that the difference between an absolutely unendurable lifestyle where you are hammered into the ground and you never see your wife and you never see the sunshine and all you do is stagger from bedside to bedside, and a very reasonable lifestyle where you do 3 weeks of service and then you're off for 6 weeks and you can travel, you can go give lectures like this one, you can participate in academic medicine, you can take trauma call, you can have an elective practice, you can do whatever you want. The difference between one system and the other is a couple of good partners. So if we had enough people in the trauma acute care system, it would become a much more livable system. It would become a much more attractive system. And people with lifestyle issues would realize, yes, I have to take every 4th night in the hospital, but the rest of the time I can walk away and do whatever I want. And I think that would make the system much more attractive. Liability protection isn't a big issue where I live. It may be a big issue where you live. It has certainly been raised as an issue for trauma centers and acute care centers who are trying to organize this kind of a system. A couple of years ago, one of my residents said, Dr. Saffle, I think you're a good doctor, but I don't want to end up like you. And I guess that could have meant a lot of things. I took it to mean that he was commenting on my surgical practice, but he might have been commenting on something else. I don't know. The greatest frustration I have faced in educating students and residents is not getting them to enjoy the burn service rotation. They all have a great time on the burn service. It's not getting them to enjoy the trauma service rotation. They have a great time on the trauma service. It's getting them to understand that this as a career has satisfactions which are unique in all of the world of surgery and that can't really be duplicated, at least in my opinion, anywhere else. I can't get them to see, as Dr. Warden got me to see many years ago, just how fun this is. One of the things you get in burn care that you don't get anywhere else is a team. And every burn center in the country has pictures like this of lots of smiling people clustered around their physician staff. And these people are all my friends, and I've worked with them for years. And it's a little surgical family that spends day and night together. And it is the most closely knit team in the hospital. I spend more time talking to my nurses than I suspect any other specialist in the hospital spends talking to theirs. And the burn team is really one of the great pluses. It's one of the great perks of being involved in burn care as a profession. And as an illustration in closing, I want to show you a patient case scenario. This was a lady who came from Nevada. You probably have your own opinions about Nevada patients. She was in a bar with her boyfriend, and they had a fight, and she stormed out of the bar and walked down the road, and her boyfriend went out and got in his truck and drove up behind her and ran over her and dragged her down this gravel road for several hundred yards and basically sanded all of the skin off of her perineum and thighs and pelvis. She had a number of rib fractures. She had a closed head injury. She had a badly mangled foot. And she was brought to our center and immediately sent to the burn unit because the burn unit does these big soft tissue injuries. And over the first 24 hours when we were cleaning her up and picking gravel out of her wound, this big lateral flap of her thigh became bluish, discolored, and was obviously dead and had to be removed. She developed an acute abdominal compartment syndrome and required a decompressive laparotomy. And in those days, we used Dexon mesh to hold those people together. We still use Dexon mesh sometimes. I kind of like it. And here she is on day 7 with this huge open abdominal wound. We're taking her to the operating room every day for debridements. She's on a ventilator. She's getting all of the critical care services that our hospital can offer. She had this very badly mangled right foot with an open fracture, exposed bone, discolored, poorly perfused skin. Our orthopedics guys didn't think she was a good candidate for a free flap given all of the other things that were going on with her, so she required a below-knee amputation. Here she is on day 10. We're getting things cleaned up. We're getting a little bit of granulation tissue. We're starting to stick down some of the lateral flaps. We initially covered her with cadaver allograft skin. We have a very good skin bank at the University of Utah, and we use cadaver allograft skin for lots of things, and you can see she's got about 5,000 or 6,000 square centimeters of allograft skin temporarily covering her. We were eventually able to autograft her completely, proceeded on with her rehabilitation. And here's her picture on day 75, just before discharge. So the irony, the most troubling irony about her rehabilitation is that she had a below-knee amputation, and she has Nevada Medicaid, and Nevada Medicaid refused to buy her an artificial leg. So when she left the hospital, she left on one foot because she couldn't get a $300 prosthetic leg. We got to know this lady very well. We spent long nights over her. We spent long days in the operating room with her. We talked to her at great length as she began to get well. The nurses became her friends. And this is a kind of patient care experience that I really don't think you can get in many other kinds of surgery. I wish I could convince residents, mine as well as yours, that this is a tremendous amount of fun. And watching this lady get well was a wonderfully heartwarming experience and tremendously satisfying, and in my opinion, more than justifies all of the inconvenience and time and trouble that was spent. So it brings me to the conclusion of my talk and to my most favorite of all surgical quotations. Even in an era of lifestyle, even in a time when we are preoccupied with salary and personal goals and objectives and wondering about whether the other guy's going to take as much call as we do, we should never forget the real reason for us being in this business is my favorite surgical quotation, which is that the bravest person in the operating room is always the one on the table. I very much appreciate the chance to be here today and talk to you and to honor my friend, Dr. Hansbrough. Thanks. So,